You, Dr. Rishabh and Ankuin for the invite, and thank you. AstraZeneca is a sponsored session, so we'll be speaking specifically about the role of Durvalumab in stage 3 non-small cell lung cancer. So the slides have been provided by AstraZeneca. So this is the mandatory slide, which tells us about the burden of lung cancer. It is the second most common cause of cancer within India. And if you see, the number of cancer deaths is quite high. It's almost when you look at the incidence, it's almost 90% of the patients. When you look at the incidence, almost 90% numbers, they end up dying of the disease. So it's a highly lethal cancer. And the treatment of lung cancer requires multiple doctors, multiple sessions in the tumor board. And specifically for stage 3 non-small cell lung cancer, after the patient is evaluated by all the doctors, including the radiation oncologist, the medical oncologist, the pulmonologist, and the surgeon, they do various tests to look at the pulmonary function tests, the bronchoscopy, mediastinal node evaluation, MRI, and PET scan for complete staging. And if a patient is deemed unresectable, stage 3, in that case, the standard of care as of now is definitive chemoradiation for that patient, provided he can tolerate the treatment. In some patients who have poor performance status or who you end up giving too much radiation to the lung, in such cases, there is an option where you can shrink the tumor with chemotherapy and then go ahead with chemoradiation. But the best form of treatment still remains concurrent chemoradiation rather than the sequential chemoradiation. So if you look at the various regimens which are there in the use of concurrent chemoradiation, earlier there was cisplatin and etoposide in the PROCLAIM trials, and the newer PROCLAIM trials have used cisplatin plus pemetrexed. We have the age-old paclitaxel plus carboplatin. And with all these treatments, if you see the median progression-free survival is around 10 months, and the median overall survival comes to around 22 to 25 months. So this has remained static more or less, even with newer chemo regimens being used. But if you use sequential regimens where you give chemo first and then radiation, the survival is much lesser, with overall survival only 15 months. So concurrent is better than sequential. Now, however, as shown before, the survival is only 25 months. So even when you give concurrent chemoradiation with curative intent, almost 50% of the patients will develop distant metastasis and 40% will develop locoregional metastasis. And the total 5-year overall survival is roughly in the tune of 15 to 25%. So there is definitely an unmet need, and there has been studies to improve these outcomes. So various trials have looked at adding to chemoradiation using some form of consolidation to improve survival. So they've used chemotherapy, they've used targeted therapy, and vaccines as well, immunological agents. But all these agents have not been able to breach that 25-month overall survival mark. Most of them are still in that area. So what all these studies which have looked at consolidation could not show a definitive improvement in PFS and OS. So if you look at the evolution of treatment, the earliest study started off with the usage of just radiation in the 1960s. And then they looked at sequential chemoradiation, where they give chemo and then radiation. And they found that that was better than radiation alone. Then came concurrent chemoradiation versus radiation, and there was survival gain of over 10 months in those patients. And to improve on that, they kept studying, and they compared concurrent chemoradiation versus sequential chemoradiation, which we discussed earlier, where concurrent chemoradiation is much better than sequential chemoradiation. They also looked at induction chemoradiation followed by induction chemoradiation followed by surgery versus chemoradiation alone, and that also did not show much difference in survival. Various consolidation regimens were also used, as we saw in the previous slide, and that also could not improve survival. So we've largely remained static over the last, let's say, 20 years from 1992 onwards. So in spite of all these tests, because of this negative outcomes, people were looking for newer treatment options, and that's when immunotherapy was looked at to see whether it could be a safe and effective option, and it could be used along with concurrent chemoradiation or sequential after that as a consolidation regimen. So there comes the Pacific trial, and the Pacific trial basically recruited patients with stage 3 unresectable lung cancer. So this was a phase 3 randomized double-blind placebo-controlled multicentric study, and patients who were 18 years or older with good performance status and with a life expectancy of more than 3 months. Such patients were taken in and randomized 2:1, and they were randomized and included in the trial within the first 6 weeks after completion of radiation. One arm received Durvalumab every 2 weeks at 10 milligram per kg for 12 months, and the other arm received a placebo every 2 weeks. Patients were stratified based on their age, sex, and smoking history. The primary endpoints were both PFS by blinded independent central review and overall survival. You had other endpoints like ORR, the duration of response, safety and tolerability, and so on. So if you look at the baseline characteristics between both arms, they fit the typical lung cancer population. Points of note are, one, the Asian population was almost 25 to 30% in both arms, which is a sizable number. So you can say this study is reflective of practices in Asia as well. The other thing is EGFR mutation status was positive in around 6% of the population, and it was not tested in almost 25% of the population. So as we know, this is the population where immunotherapy may not have that much of activity because there are other driver mutations, but a small percentage, 6%, did have this. The other baseline characteristics were what importance is the PD-L1 expression, in which a TC score of less than 25% was seen in almost 40%. More than 25% was seen in around 20% of the population, and it was unknown in 35%. So you can say that the majority had a low PD-L1 expression, and histology, both squamous and non-squamous, were equally distributed, and majority were obviously smokers. Almost 75% of patients were smokers. The prior chemotherapy received, almost 100% received concurrent chemo radiation, and almost 25%, roughly around 1/4 of the patients, received induction chemotherapy. So this is interesting because these patients would have received slightly different regimens than many others, but it goes to say that this trial looked at the effect of immunotherapy in that population as well. So moving on, just to look at that subgroup again, this slide highlights that, as we said, chemoradiation was received in the majority, and induction chemotherapy was there in 26.8% of the population. Now, this is the updated 5-year survival of the Pacific trial, and as you can see, the curves remain separate after the end of 5 years, with a difference of 42.9% versus 33%, almost a 10% difference. And if you look at the median overall survival, it's 47.5 months versus 29.1 months in the placebo. So that's almost an 18-month survival, or 1.5 years survival benefit with the use of Durvalumab as consolidation. So that's quite good. The hazard ratio is quite decent at 0.72 as well. So this is the first and only approved immunotherapy in stage 3 unresectable lung cancer, which is giving you an overall survival of 42.9. It's almost 43% at 5 years. If you remember the old data, the range was from 15 to 25%. So we are almost able to double the survival from the old data. If you look at the progression-free survival, here, this is also superior with the use of Durvalumab. It's almost 17 months of progression-free benefit versus 5.6 months in the placebo. So both these endpoints, the primary endpoints, were satisfied and met, and this drug was obviously FDA approved. And as we see, the progression-free survival at 5 years is 33.1%. What about subsequent therapy? So, as in real world practice, in the Durvalumab arm, 41% of the patients received subsequent treatment and 54% of the patients in the placebo arm received subsequent therapy. So there are many dropouts because of progression of disease and patients' performance status being quite bad that they're not able to receive subsequent therapy, but it's largely balanced between the both arms. And what were the subsequent therapies received? The majority was a platinum doublet chemotherapy, and then you had use of immunotherapy. Obviously, the placebo arm or the control arm received more immunotherapy because the other arm was already exposed to Durvalumab. So 13% of patients did receive immunotherapy. This number is a little lesser than expected, but probably depends on various factors and accessibility. But yeah, in some more patients could have received immunotherapy in the control arm as well. Other than that, targeted therapy was given in around 5% of the population. So subsequent therapy has been described and detailed in the updated analysis. Now, what about the site of progression? How do these patients progress with their disease? So in Durvalumab arm, there was reduced rates of first progression, obviously, and the most common site of progression was intrathoracic, which is the same area which you treated, 80% versus placebo 74.5%. This table highlights the same thing, which says that the majority of the progression is 80% has been seen in the intrathoracic area. Now, this is the time to intrathoracic progression, which is just basically giving you more information specifically to the local progression. It's something similar to the progression-free survival. So the time to intrathoracic progression was almost 25.2 months versus 9.2 months with the placebo. So Durvalumab will help you reduce the intrathoracic progression. So the symptomatology, the breathlessness, those kind of symptoms can be obviously reduced with the use of Durvalumab. If you look at extrathoracic lesions, there is obviously Durvalumab performed better, and only 8.8% had extrathoracic lesions. And the majority of the patients, as you can see here, had 1 to 2 extrathoracic lesions on first progression. Safety-wise, majority of patients in both arms, almost 96%, both of them had some side effect or the other. Grade 5 side effects were more in the placebo arm, 6.4% versus 4.4%. So this is important because 5% of your population are going to die you in the end, within 5 years because of, some form of chemotoxicity or, drug toxicity. Discontinuation rates were 15% versus 10% in the placebo arm, and serious adverse events were 30%. Now, if you look at the most important side effect, which we worry about with immunotherapy and the use of radiation together, especially with CTRT in lung, is pneumonitis. Now, any grade pneumonitis was seen in almost 34% of the population versus 24%. So even the placebo arm had a high level, probably because of the post-radiation pneumonitis, which was there. 10% higher with the use of Durvalumab because of the additional effect of immunotherapy. In that, grade 5 was 1.1% versus 2.1%, and grade 3 and 4 was 3 versus 3%. And more patients had to discontinue Durvalumab because of this pneumonitis. So roughly this tells you that 1/3 of your patients will develop pneumonitis. So you have to keep a lookout for that. Keep the pulmonologist in the loop, and I would say probably keep looking at pulmonary function tests or do CT scans if you have a doubt of pneumonitis. Now, if you look at the safety based on time from radiation, this slide basically looks at the aspect of whether starting immunotherapy earlier, like within 2 weeks of radiation, could cause more harm versus starting immunotherapy after 2 weeks of radiation. So as you can see, 39, almost 40% of patients developed some form of pneumonitis when you did it within 2 weeks versus 32% after 2 weeks. So for safety wise, I think it's safer to start immunotherapy at least 2 weeks after the last dose of radiation. It's almost comparable numbers, but slightly less chances of pneumonitis you'll have starting after 2 weeks. So, is that data on real-world data regarding the use of Durvalumab? Yes, this is one of the French studies, and this also looked at the timing of the start of Durvalumab. And this was a study in which this drug was given a special temporary authorization for use in France, and 561 patients were given this drug. These were patients who were not enrolled in other clinical trials and who deserved the medication. So the eligibility criteria was stage 3 non-small cell lung cancer who were not in any other trial and who did not have any disease progression after chemoradiation. And they should have received at least 2 cycles of platinum-based chemoradiation. Their radiation doses have also been specified and with good performance status, and it had to be started within 6 weeks of Durvalumab, means within 6 weeks of the completion of radiation. The exclusion criteria was unresolved grade 3 or 4 toxicity, grade 2 pneumonitis, even persistent after 6 weeks, or if they received prior immunotherapy, or if they had any immune syndrome history. So this is, I think, very important because these are the patients where you should avoid Durvalumab. You still have significant pneumonitis, or you have good toxicity, or if you have severe immune conditions which are not controlled. So the patient characteristics were basically very similar to that which is there in the Pacific trial, nothing major to highlight there. And when the patients were enrolled into this study, almost 78% had partial response with just chemoradiation, 15% had stable disease, and 6% had complete response. The interval between the end of chemoradiation and start of Durvalumab was less than 2 weeks for a very small proportion, 2.5%. The majority received it between that 2 weeks to 6 weeks, and it was almost more than 6 weeks in 40% of the population. So even after 6 weeks, a large number, 40% of the patients took Durvalumab. And what they looked at is the data of the available 360 patients. And what they found out is the disease control rates, complete response, partial responses, all of them were more or less comparable to the Pacific trial. So even if patients got enrolled into it after 6 weeks of therapy, you could almost get the same outcomes as you see in the Pacific trial. And this tells you that you can use Durvalumab. Suppose you have a patient with some form of pneumonitis which is slowly resolving. So even after 6 weeks, maybe if you take a 2-3 week extra break and then start immunotherapy, you can probably continue it. But definitely you'll have to keep monitoring for any worsening of pneumonitis. So this is what this data, it's real world data, it's not randomized, but it gives you a possibility of use. So finally, to conclude, the use of Durvalumab slowly, as we said, from 15 to 25%, the survival is going up to 43%. So the aim was to almost make lung cancer a chronic disease, and the patient taking some form of treatment or the other, but the disease kept in control. That is the final aim of the treatment of this unresectable lung cancer. So the final takeaway messages are the overall survival in the Pacific trial was 47.5 months versus 29 months for placebo, a good hazard ratio of 0.68, progression-free survival of 17 months versus 5.6 months. All subgroups benefited from treatment, although I think the EGFR mutated arm did not do well that much, so it's good to look at that for any driver mutations before proceeding with immunotherapy. The 5-year overall survival, 43%. The percentage survival is 5-year OS is 43%, which is quite good. And almost 1/3 of your patients remain alive, free and free of disease progression. That's your PFS benefit is almost 33% at the end of 5 years with the use of Durvalumab as consolidation. And obviously, intrathoracic progression is the main site of failure, but it's much lesser than placebo. It's decently tolerated. Look out for pneumonitis. 30% of your population, 1/3, will develop pneumonitis. And even if you want to start the drug after 6 weeks, there is some data for it, so it can be offered after that as well. I think that's the last slide. Thank you for your patient listening.
Thank you, Arun.